welcome to everybody. Thank you for being here. We're really excited about this conversation today with, obviously, President Biden being inaugurated this past Wednesday. It certainly presents some potential changes and uncertainty around the healthcare system. And as business owners, it's good to be having these conversations about what we can potentially expect. So we're going to talk about things today, centered around a lot of different topics. We'll try to cover a lot of ground, but, what is the administration going to be focused on in the next few months? What could the impact to businesses be? How does the COVID or coronavirus response play into this? Et cetera, et cetera. So there's going to be a lot of topics to cover, but again, I can't stress enough, we would love questions from the group so that we can make sure we're highlighting those things that are important to you. So with that, I'd like to introduce myself. I'm Elliot Bassett, Chief Operating Officer for Ellerbrock-Norris, and we have Seth Denson on the call who's going to be doing the majority of the talking today. But Seth is one of the most sought-after minds in healthcare. Just in the last 3 weeks alone, he's done over 20 national interviews to discuss the future of healthcare and this exact topic that we're bringing to everybody today. He is the chief strategist for our healthcare team, so working through the strategies for our clients on how we can best manage healthcare within our organizations and truly bring that back to a benefit for our employees. And so he is very well versed in this topic, and I think will be able to give us some good guidance moving forward. We will be following up the talk today with a survey that just asking some questions about what you thought. Ideally, if we focus the call around questions, we'll get those questions answered, but we want to know if there's other questions we can answer for you. So if you respond to that, if you see it and respond to that, we will make sure that we get you a special gift, a signed copy of Seth's book, The Cure. If you haven't seen that or read it, it is a blueprint to how we can help solve our healthcare crisis in America. So with that, Seth, welcome. Hopefully I did the intro justice. You're having a lot of conversations with folks in the Biden administration over the last few weeks and months. What in general does, the healthcare landscape look like over the next year here in the Biden administration?
Well, listen, and to preface that, I've had conversations on both sides of the aisle. And interestingly enough, in many ways, some of them are aligned. Everyone right now is focused on the pandemic. So all energy efforts are focused on COVID, getting vaccines rolled out, trying to create a nationalized platform or blueprint, if you will, to get vaccines into more citizens quicker, to ramp up production of vaccines. The Biden administration is focused on 100 doses within 100 days. It's not as lofty as a goal, I think, as what we would have anticipated about a week ago. But just yesterday, there were just almost 1 million vaccines handed out. So if we can keep that pace, then they'll hit that 100 vaccines in 100 days. So I think that's obviously priority one for the new administration. And so, all focus will be on that. All political capital will be spent on that. But in stepping back and thinking about where does healthcare go from there, I think that there are two key things to understand. First and foremost is from a legislative perspective, we don't have to go all that far back to recognize that history has taught us that any administration that controls both houses of Congress typically gets one thing done, right? For Obama, it was the Affordable Care Act. For Trump, it was the Tax Cuts and Jobs Act. So I think what's on the minds of many right now is, what will Biden's thing be? Will he focus on the environment? Will he focus on healthcare? Will he focus on, a number of other things like college tuition that are out there that are being talked about? The insiders that I talk to are telling me that from the Biden camp, it's going to be healthcare. They're going to want to double down on what President Obama did under the Affordable Care Act. They are wanting to repeal many of the things that Trump did, whether that be through the Tax Cuts and Jobs Act, things like the individual mandate. They want to bring that back. Or things that Trump did through executive orders, like the expansion of health reimbursement accounts. So if you're a small employer under 50 employees or self-employed, that's something that could impact you in the weeks, months, and even years to come. So those are going to be the things. But the reason that the Biden camp is largely saying that healthcare is going to be their primary focus is really twofold. The first is when you poll Americans outside of the economy and the pandemic, healthcare by and large is still number one on their mind. And second, it's something that President Biden is very familiar with because of his involvement with the Affordable Care Act. And understand that coming up in June, we still have a Supreme Court case that's going to be heard on the validity of the ACA. I believe that the Affordable Care Act will be upheld. We can get into that maybe at some point today if there's time as to why I believe that. But by the way, my belief in that has nothing to do with my political preference of that. It just is my legal perception of that. And then secondarily, when you're following the pandemic, recognize that in Washington, campaigning is difficult, but it's certainly easier than legislating. And there's only so many things you can do through executive order. The Affordable Care Act passed because of many deals, one of which was very specific to the state of Nebraska called the Cornhusker Kickback, which was Senator Ben Nelson was against the Affordable Care Act. And because of some jockeying and some things that maybe were thrown to the good state of Nebraska, they were able to get it over the goal line. Biden will have a slimmer margin in the Senate than Obama did when he got the Affordable Care Act passed. And so he's going to have to use every bit of political capital. How do you do that? You do that when you focus on something that's on the forefront of Americans' minds. And second, following the pandemic, you've got some narratives out there that I think Biden and his administration can capitalize on when they're talking to Americans about the need to do something expanding access to healthcare.
Awesome. No, I think that's a great overview. So, you and I have had this conversation in the past. Everybody, when they think of President Biden and what he might do, there's, some folks take it to the extreme, right? And there's talk about public option and some of those things. Maybe just give your thoughts around pluses and minuses of potentially what you're seeing and what that could lead to, because there's positives and negatives to everything, right?
Yeah, absolutely. And we want this conversation to be as bipartisan as possible, right? Let's focus on the details and the facts, not on the politics of it. But anytime you're talking about politics, it's going to find its way into the conversation. From a positive, let's start there, because again, we don't have an actual plan to dissect at this point. What we do have is a campaign analysis. So if we go back and look at what Joe Biden campaigned on, interestingly enough, if you went to go try to find that on his website, you'd have a real hard time finding it now. They have effectively taken everything that he campaigned on off of the website. It's still out there, but you would have had it in a link prior to and found a way to navigate towards it. Fortunately, we did. And we had saved all those links, so we were able to go find some of this and even do a deeper dive. I'll also follow this up to say that I have an op-ed that I've written that will be published later today on newsmax.com. So on newsmax.com, my op-ed will be there on kind of what the future of Biden care might look like based on his campaign promises. So let's start with the positives, right? So first and foremost, Joe Biden is big on focusing on prescription drugs, right? This was a key point of the Trump administration, and Joe Biden wants to double down on that. These were actually areas where they were aligned in their beliefs. So first and foremost is how Medicare and Medicaid negotiate prescription drugs. So what I'm going to do, I'm going to talk about the positives, then I'm going to talk about how that might impact the employer market, because I think that's really important to tie those two together. So the Joe Biden camp wants Medicare and Medicaid to be able, Centers for Medicaid and Medicare Services, to be able to negotiate directly with pharmaceutical companies. So roughly 40-ish, 45% of all drugs bought in the United States are bought by Uncle Sam, which means that they're bought by you and me as taxpayers, right? Uncle Sam, through the Medicare and Medicaid programs and the VA, is the largest procurer of prescription drugs. But as part of the Medicare Part D program that the Bush administration brought in, there was a component of that law through the negotiation process that said that the federal government could not negotiate directly with pharmaceutical companies. Now, I've gotten the question a lot of times now, why would they ever put that in the law? Well, we don't necessarily know specifically, but we can guess that it's probably because the pharmaceutical industry has one of the largest lobbying arms in Washington. And so what happens is the way that drugs are negotiated now is effectively a percentage off of the AWP, or average wholesale price. Well, that's set by the retail market, and it's controlled by the pharmacy benefit managers, or PBMs. And if you've been on any of our virtual roundtables before, you know that we spend a lot of time talking about PBMs. And so one of the things that the Biden administration is in favor of is removing that mandate, removing that part of the law that says that CMS can't negotiate. And in reality, many estimates are that this would save taxpayers about $15 billion a year, whether that be users of Medicare and Medicaid, or whether that be just our tax dollars that are paying for this on behalf of the government. I'm in favor of this. However, I'm also recognizing this could have an adverse effect to the employer market. Recognize that pharmaceutical companies today are extremely profitable, but they are the fraction of, we'll call it EBITDA margin, that pharmacy benefit managers do. Remember, the pharmaceutical industry makes the drug. There's costs associated with that. You have ingredients cost, you have research and development cost, you have the cost of getting it to market and production and all of that. And so their margin is much slimmer, although greater because they are the manufacturer in its aggregate, but slimmer on the percentage than the PBM. PBM doesn't make anything. PBM negotiates things. So there's not a lot of overhead cost to the PBM to negotiate the drugs, and they get the highest level of spread. So the profit margin for the PBM is extensive. And unfortunately, over the last number of years, we being America, have made PBMs uber powerful. I write about this in The Cure, that in my opinion, hospital systems and PBMs are the too big to fail now. Although I think that we could get PBMs out of the way, hospital systems not so much. Big conglomerate hospital systems I'm talking about, not more regional hospital systems. But you know, from a PBM perspective, you got to know that they're going to fight hard against this. The pharmaceutical company is going to put their weight behind it too, but the PBMs are going to fight hard to make sure that CMS cannot negotiate the price of drugs. I would love to see it happen, but it probably won't for that very reason. If it did, here's the cause and effect of that. We would see a short-term spike in the cost of the employer market. When you try to reduce the cost of things by federal government involvement, you never reduce the true cost of things. You just squeeze the balloon and the air moves to a different part of the balloon. And just like we saw in the Affordable Care Act, when the federal government got involved in reducing the cost of health insurance, it didn't actually reduce the cost of health insurance. It provided subsidies to reduce the cost of health insurance. And as a result, the cost of health insurance actually went up astronomically. So while I like the idea that Uncle Sam should be able to negotiate the price of drugs, it needs to be done in a way that regulates the amount that the pharmaceutical industry, and by the way, I'm not for price fixing, but you have to understand that you can't solve for one side of this without solving for the other. And the other mean that you need to either set protocols by which pharmaceutical companies lose access to their patents sooner, or you put protocols in place that says that there is some level of cap to the amount over and above Medicare that employers and private pays would have to pay. Or the third thing is that you could create a structure by which pharmaceuticals are required to be completely transparent as to all of their costs. That's the one I'm most in favor of, because transparency leads to consumerism. And the consumer is the greatest mandator of our economic system. So if the consumer can have more information, then we can derive the cost of goods down through information. So, okay, so that was one. Sorry, that was one positive thing. This is a long question, a long answer, right? The second thing is to enforce antitrust laws. This one I'm very passionate about, because what we have seen over the last decade, really over the last 2 decades, but almost in hyperbolic speed over the last decade, is the consolidation of hospital systems. You're seeing it dramatically in the state of Nebraska with CHI. So what happens is CHI goes in and they buy a number of hospitals, right? So Nebraska Heart is a perfect example of that in Lincoln, right? Nebraska Heart Hospital is a fantastic heart hospital. However, they were bought by CHI. And once CHI got their hands in there, the cost for Nebraska Hospital skyrocketed. The argument for hospital consolidation is always that administrative costs can get cut, therefore prices can go down. Not one time in history, to my knowledge, has that ever been the case. What they do is they consolidate the market, they control the market, and they can charge what they want. And that's what's happening. So the Biden camp has actually called that out and said, we want to enforce antitrust laws in two key areas: hospital consolidation and insurance market consolidation, both of which I'm a huge fan of. I would love to see that happen. Taking that to a secondary layer, we talked a moment ago about pharmacy benefit managers, or PBMs. Roughly 70% of all drugs in the United States are controlled and distributed by one of 4 PBMs. All 4 PBMs are owned or own insurance companies. So you've got Express Scripts, which owns Cigna, Optum, United Healthcare, CVS, Aetna, and Prime Therapeutics, Blue Cross, Anthem. So I have just mentioned 70% of all drug distribution by one of those carriers. And as we go through the day and start talking about what can I as an employer do to solve for this, well, the first thing I would tell you is if you're working with one of those 4 PBMs in conjunction with them also being your administrator, you have removed any and all checks and balances to make sure you're not getting hosed. So in other words, if United Healthcare or UMR is your administrator of your plan and Prime or Optum is your PBM, you're spending probably 20 to 30% more on your prescription drugs than you need to be. And you'll never know it because they'll never share that with you because there's nobody checks and balancing that. So while I'm not saying you should never work with Optum, and I'm not saying you should never work with United Healthcare, you shouldn't work with both of them together because, again, you removed any and all checks and balances in the system. The same thing could apply with Cigna and Express Scripts, with Blue Cross and Prime Therapeutics. Here's the key, though. You got to watch out for Blue Cross and Express Scripts, too. So before Express Scripts bought Cigna, there was a long-term contract made between the Blues and Express Scripts. And if you're on one of those old contracts, you're still getting hosed. And so what you need to look at from your plan, if you're fully insured, we're gonna break this apart. We'll talk about fully insured in a second. But if you're self-funded right now, you need to look at who's your TPA and who's your PBM. And if those two are linked in any way, you need to have a deep conversation with your advisor as to why. And is that the best thing for you? And you need to have an independent third-party analysis done on your pharmacy spend. There are many organizations that can do it. We can do it at Ellerbrock-Norris. We don't charge to do that for you, but you need to have that independent study done because that's going to tell you what your ingredient costs are and the amount you're paying over and above that if you did not have those two linked. So that's another positive from the Biden administration that I would love to see happen. Will it happen? I don't know. Another side of that, buy pharmaceuticals from authorized nations. Again, something that the Trump administration had already started, and the Biden administration looks, based on their campaign promises, that this is something that they want to continue. So right now, the FDA serves as almost a protectionism organization for the pharmaceutical industry, because by and large, testing done in other nations, as well as pharmaceutical drugs in other nations, are rarely allowed to be purchased here in the United States. That keeps competition out. That is something that needs to go away. Certainly, we don't want pharmaceuticals coming in from third world nations that don't have high-level protocols. And nobody has higher-level protocols than the FDA here in the United States. But there are countries that have very extensive protocols that I think that we can begin to trust so long as they go through some type of research and study. Countries like Canada, Germany, by the way, produces more pharmaceuticals than any other nation, even more than the United States. Great Britain, France, Switzerland. These are all countries that have very strict protocols as to their pharmaceuticals. And I think that if we were able to find a way to allow a free trade agreement, this is part of trade agreements now, though, to allow those countries to sell their goods here in the United States, it would in turn drive the cost down of pharmaceutical drugs. And secondarily, it would help by squeezing the PBMs out because the PBMs don't have contracts with those other nations. And then improve the supply of generics. So this is kind of where I wrap my positives of Biden's plan. So Joe Biden's plan has also, based on his campaign, said that they want to allow generic companies to get information on name brand drugs ahead of time before the patents run out. So that way they are ready to hit the ground running as soon as that patent runs out. So there is certainly a time right now that the FDA and the Federal Trade Commission allows for information on patents of prescription drugs to be provided ahead of time. But Joe Biden wants to extend that. So that way there are plenty of generic options once a patent runs out, that the generics can be expanded for high-cost drugs. Prescription drugs is the fastest growing area of our healthcare sector in cost, and also the fastest growing area of profit margin. So this is something that the Biden administration is focusing on heavily. I'm pleased to see that. That's really where the positives, in my opinion, end. And so I'm going to pause there if there's any questions or thoughts or comments from you, Elliot, or anybody that's listening in before I start talking about maybe some of the negatives.
Yeah, we have not gotten questions in the chat window. Please, that's a great reminder, though, to post any questions you do have. We'll make sure that we get to those. And we're certainly going to address this from the business owner perspective and what we can do, as Seth mentioned. But I think, Seth, it's great. Let's talk about maybe the potential negatives that we're going to see and we need to be cognizant of, and then we'll address what we can do about it.
Yeah, so I'm gonna talk first about the negative. I think from a political perspective, there's about half the country that's going to hate this component of what the Biden administration has proposed as part of their plan. I'm not going to make any personal commentary on this because I know it's a very sensitive topic, and that's just not what we're going to dive into today. Maybe sometime if we're somewhere at a restaurant, I can give you some of my opinions on it, but I'm not going to do that today. I'm just going to give you the facts, as Joe Friday would say. So part of his plan is to repeal the Hyde Amendment. So now the Hyde Amendment is federal law that states that the federal government cannot use taxpayers' dollars to fund abortions. And I know that that's a sensitive topic on both sides of the aisle. Joe Biden and the administration wants to remove that law. Now, interestingly enough, Joe Biden was very influential in getting that law passed originally, many, many years ago, but he wants to remove it now. What that means is that taxpayer dollars could go to help support and pay for abortions. Whatever your political perspective on that is your political perspective. Just know that that's part of Joe Biden's plan. The other component that is part of his plan that is very much a perceived negative on the conservative side of the aisle is that he wants to eliminate what are called trap laws. Now, trap laws sound really negative, but what trap laws are is that in the event of an abortion, there has to be an ultrasound. And if you are under the age of 18, a parent or guardian must be informed prior to the procedure being performed. Both of these, the Biden administration wants to remove. And again, that really gets people enraged on one side of the aisle, and the other side of the aisle likes this idea. The argument for removing trap laws are areas of incest or abuse. The areas against it are obviously that do minor children have the capability to make these decisions, and does that create a path that maybe nobody wants to go down? Again, I'm going to end the conversation there from my own political opinions on that and my own personal opinions on that. But know that those are two very key components of what the Biden administration has proposed as part of their health plan. Other key areas, and this is where I'm going to now start shifting into how this is going to impact employers directly, is that Biden wants to expand tax credits to lower health insurance premiums. Now, I want to make sure that I clarify two things. Whenever we hear about expand tax credits, that means increase taxes because that money has to come from somewhere. Right. So under the Affordable Care Act, a key component were tax credits based on persons that fell below the 400% of the poverty line. So if you were below 400% of the poverty line, you could go to the open market, assuming that your employer did not provide quality coverage that was deemed affordable, and you could utilize tax incentives or tax credits to lower premiums. Here's the reality. It didn't lower premiums. It just lowered your premiums. And I think that's a very important distinction to point out, because health insurance companies, as a result of this key piece of the law, in conjunction with the entirety of the Affordable Care Act, have done quite well over the last decade. Many are over 1,000% stock price increase since the passage of the Affordable Care Act, because history has told us anytime the government gets involved in subsidizing anything, the cost goes up. That's just truth. You can fact check that one all you want. When the government is paying for something, costs go up. So if the government starts talking about increased tax premiums or tax credits to lower health insurance premiums, you have to dissect that conversation because there's a couple things that are missing there. It means when they say tax credits means tax increases on a big chunk of our population. And then when they say to lower health insurance premiums, they just mean lower insurance premiums to some. That doesn't actually mean lowering health insurance premiums. It's just your out-of-pocket cost for them. Insurance companies will still do quite well. That's why we haven't heard the insurance lobby in advocating against this all that much these days. They're for this. So that's important. The other component of that is that Biden wants to remove that 400% cap, right? That says, hey, if you're 400% below 400% of the federal poverty level, you get access to this. Biden wants to say, no, we got to remove that cap altogether and really make it open-ended, that anybody on a graded scale could get access to tax credits based on their income. Now, interestingly enough, I'm actually not opposed to this. And I'm not opposed to this for this very reason, as long as it's done appropriately. Because one of the things that was the indirect consequence of the Affordable Care Act was that if I, as an employee, have access to health insurance and my spouse can enroll, that doesn't mean that my spouse that does mean now that my spouse can't qualify for a subsidy. Well, for many employer plans, the cost of providing spousal coverage has gone astronomical. Again, going back to something I said earlier, when the federal government gets involved, the balloon gets squeezed and the costs get moved around. And so as a result, many people who spouses don't work can't get government pricing for their spouse just because they themselves have access to a health plan. This is something I would like to see changed, and it would make it more fair and balanced across the board. And likely we haven't seen specific language in Biden's plan that's where he wants to go with this, but typically that is tied to the elimination of the 400% federal poverty level. The second piece of this, and this is where I'm okay with this, are self-employed persons or 1099 persons. Right? So if I'm self-employed or 1099, on paper, I might make more than 400% of the federal poverty level, but because of the inflation of the individual market, in large part because of federal subsidies, again, remember, when the government gets involved, prices go up. I am self-funded, I'm self-employed, but I can't afford health insurance because I'm above the 400% poverty level, which means I don't qualify for tax credits, and the cost of what I can get has skyrocketed in the market. And so that's where I'm okay with that removal of that cap. And making it more, don't use this word often, but I'm going to say equitable, and across the board going forward. The lower the income payment from 9.86% to 8.5%. So this is going to impact employers, right? So remember that under the Affordable Care Act, there's two components that employers have to qualify for if they are what's considered an ALE, or an applicable large employer. Now, remember, applicable large employer means in 50 or more employees, not full-time employees, employees. So you could have two part-time employees that if you add their hours up, that makes one full-time employee. Therefore, you have to add those two part-time employees as one equal full-time employee. So it's all about hours worked. And so what the current federal law under the Affordable Care Act says is that if I'm an employer and I'm an applicable large employer, I have to do one of two things. I have to provide health care coverage to employees that meets minimum essential coverage. These are those things that are covering those basic preventative care procedures that under the Affordable Care Act are considered essential. I have to provide a plan. Doing that means that I have satisfied what's called the pay or play provision. Now, this is the provision that says if I don't, I'm going to pay $2,000 per year per employee, less the first 50 employees. A lot of moving parts in that 2,000-page bill that had almost 20,000 pages of regulation thereafter. So that's part one. The second part, and this is where the Biden provision would come into play, you also have to mean that it's affordable. So for an employer to meet the affordability, the cost of health insurance that must not exceed 9.5%, or actually that's gone up through inflation to 9.86% of the employee's wage. Biden wants to lower that to 8.5%, which means you as the employer will pay more because you have to cover more of the cost. Okay, so that is a direct impact to employers that provide health coverage to their employees. The third component being MVP, minimum value plans. This means that you have to have a plan that meets actuarial value of 70% or more, and that's where that will you have, I'm sorry, 60%, and that was where that will have to comply. So effectively, you have to have hospitalization coverage, no lifetime maximums, things like that. That is the one that has to be deemed affordable. If it's not, while you may have satisfied the $2,000 pay or play penalty, you can have the $3,000 penalty for anybody who then goes to the exchange to get coverage because your plan isn't affordable. Okay. And so that is the component that would be changed here. Other pieces of the Biden plan are free insurance to non-Medicaid expanded states. So effectively, remember that there were, I think originally there were 27 states that chose not to expand Medicaid coverage under the Affordable Care Act. Matter of fact, that was a big part of the Cornhusker kickback that Ben Nelson negotiated in his deal, because he said that there was a sunset on those provisions. And the big concern for the state of Nebraska was that when that sunset happens, state of Nebraska still is going to have to provide Medicaid coverage, but the federal government isn't going to continue to provide assistance, federal funding assistance. So that was something that Ben Nelson negotiated in, called the Cornhusker kickback, was that the state of Nebraska would get extended financial assistance from the federal government as a result of the expansion. So what Joe Biden wants to do is say, hey, for all those states that didn't expand Medicaid, we're going to effectively make you expand Medicaid. That's a big part of the plan that he campaigned against. And then, as we've already mentioned, he wants to bring back the individual mandate. And then he also wants to institute auto-enroll provisions where people would be automatically enrolled and they would, in effect, have to opt out. So those are kind of the key components until I start talking about the public option. But I'm going to pause there to see if any have questions before we start diving into the public option.
We do have one question that came up, Seth, related to the ACA. Do you anticipate changes to the W-2 look-back affordability threshold?
Nope. No, I do not. I think that the look-back provisions that are part of the ACA were codified on January the 20th. They're not going to change. I think that the look-back provisions are what they are. I don't think that we'll see a 30-hour work week go away. Remember, a big component of the Affordable Care Act was that they classified full-time employees at 30 hours. Now, one thing I will say, and this is just something that we've looked at this extensively over time, and I'm going to get super geeky through this, so just bear with me. There's a lot of latitude that the federal government under the ACA provides in the look-back period for purposes of how you classify employees. So you can classify employees in one of three ways, right? Part-time, full-time, or variable. Okay? Now, the variable is really the key component of the look-back period, although we can argue that part-time, full-time was, but those are definitives, right? Part-time is they are not working more than 30 hours. Full-time is they are working more than 30 hours. The variable classification effectively means we don't know. We really don't know if they're going to work that. And the federal government allows you to create a look-back period as part of the ACA, where you can say, hey, I'm going to track their hours, and I'm going to determine over the course of time whether or not they're full-time. Now, you can set that structure really however you want, so long as it doesn't exceed 12 months. Okay, so you could classify an employee as variable for up to 12 months. But here's the tricky part of the law that is getting employers into a lot of trouble right now. And so here's your free takeaway advice today. If you are on a 12-month look-back period, you need to understand that the federal government says that you can have up to a 60-day administrative period to determine variability. So if I have a variable employee, then and remember that under the ACA, you can't allow a full-time employee to not have access coverage for up to 90 days. That's not first of the month following 90 days. That's 90 days. So and then they allow for up to a 60-day administration period for purposes of determining full-time status and then being offered benefits. So many employers did first of the month following 60 days as their protocol for variable hour classed employees, just to make sure that they're doing this right. But many employers got really bad advice because many brokers and advisors and payroll companies told employers that you can do a 12-month look back, track the hours for 12 months, and then you can then allow employees first of the month following 60 days of that determination. No, you can't. So the provision of the Affordable Care Act said that the maximum amount of time that an employee cannot have access to health insurance is 13 and 1 partial month, not 14 months. So if I track somebody for 12 months, and then I do a 60-day, first of the month following 60 days, guess what? I'm into the 14th month. I'm now in violation of the ACA, which means that you can be penalized for not providing access to coverage. So here's the solution to that. You need to go look at how your plan is set up. If it's set up for 12 months, you have one of two options: changing your eligibility to be first of the month following 30 days, or change your look back period to being 11 months. That gets you inside of that 13 and 1 partial month window on both ends of the spectrum. So it's important that you make that note. Take a look at your plan, how it's structured, how your look back period is structured. That's a very important thing to make sure that you're focused on so that you don't get that surprise penalty that may be headed your way. And by the way, the federal government is 2 to 3 years behind on issuing these penalties. So, and there's no statute of limitation either. So we have actually had clients who have retained us over the last 12 months who are getting penalties from 2017 now because they weren't set up appropriately. And so, you want to go ahead and take a look at your plan now and make sure you get that one fixed. Any other questions that have come in?
Yes. Yeah, we did have one for this part for sure. Going back to the $3,000 penalty for employers if one of your employees goes to the exchange in lieu of enrolling in your health care plan, does that include state aid? If that
if you're talking about the state Medicaid programs? This
was a question from Katie Bear. Yes.
Yeah. So it has nothing to do with the state as much as it means, did you provide affordable plans? Okay. So if the Medicaid expansion was part of the Affordable Care Act, it is likely you could be penalized if you are an applicable large employer and you are not, that's the key word, not providing affordable coverage that meets minimum value standards. Now, each state controls their own Medicaid program, and whether or not they took the Medicaid subsidies specifically from the federal government as part of the ACA is a key component of that. My assumption, and I'm going to leave a little room for error there, is to say that, yeah, you probably could be penalized, but we can certainly dive in deeper if we know the specifics of your plan and what's going on, and if this employee is in the state of Nebraska or Iowa or somewhere else in the Midwest.
Perfect. And we did have one more question, Michael. I think we'll get to that when we talk about the impact of business owners, but it was just related to how does this specifically affect small employers, Seth, under 20 employees. So we'll make sure to catch that here, Michael, before we adjourn. But Seth, maybe before we do get into the, what can I do or what should I be expecting as a business owner? I know you were going to hit quick on public option, which just your thoughts there, which obviously that term means a lot of different things. And so just maybe before we hit on, we got about 20 minutes left in the scheduled time. So maybe give us your quick thoughts there, and then we'll talk through the potential impact or what a business owner can be looking at.
So obviously the key provision, or I should say the headline provision of Biden Care, as we'll call it, is a public option. And this is meant to actually allow the federal government to become an insurance company and compete against the private insurance market. Now, I'm going to answer this in two ways, and I'm going to try to remain as apolitical as possible in my answer here. And certainly there are governments that we can look at in Europe and other parts of the world that have done this successfully, where they effectively have two types of systems. So a public option, I'm not necessarily completely opposed to, and I know that's going to surprise a lot of people that know me well. I am opposed to it in the way that our healthcare system operates now. And here's why I say that. So Medicare and Medicaid pay a fraction of what the private pay system does today. So Medicare and Medicaid in many states is about 250% less reimbursements to private hospital systems and public hospital systems than private pay systems. So if I go in under Medicare for a procedure, and I go in for that same procedure under, let's say, a Blue Cross Blue Shield, likely I'm paying 250% more of actual money out of the pocket. Not me personally, but my insurance plan, which means me personally on the back end, because at the end of the day, it becomes my health insurance premiums of that procedure. Nebraska, you guys do it right. You're actually closer to 400%. So if I were to blanket the state of Nebraska across the board, Nebraska actually pays more on average in the private pay system they do in Medicare and Medicaid. So here's why the public option is important to note. If the public option became real, likely we would see the private pay system increase exponentially to offset that, because many hospital systems can't operate on Medicare reimbursement and Medicaid reimbursements alone. They just can't do it financially. And so they shift the cost into the private pay system. So what does that mean for you? If the public option comes in, your costs are going to go up in the private pay option. That's just likely the reality. Again, going back to something I said, when the federal government gets involved in paying for something, the cost of that which it's paying for goes up. Remember, health insurance is just the finance arm of the healthcare system. So if the federal government gets involved, the healthcare system's costs will go up to offset the federal government's reimbursement rates, and therefore the cost of the private pay system will go up. Now I'm going to pause there. I'm going to talk about what other nations have done that have a public option, that have done it well enough that I would be okay. So I'm clarify when and where I would be okay with this. And I'm okay with it in only two areas. One is if the federal government, by way of identifying that they wanted to provide a public option, made it more of an HMO-like system where the federal government then also owned the hospitals themselves. So you have a private system and you have a public system, and they do not intertwine. We are decades away from that ever becoming a reality, but that is the one area where it could potentially work. Because what would happen is you would not then shift the cost to the private pay system. So what I mean by that is that there would be a public hospital and there would be a private hospital, and those two systems would work interdependent of one another. I personally believe that that would actually drive down the cost of the private pay system as well, because what it would do is it would mean that those private pay hospital systems would not have to be subsidizing their losses that they take on government reimbursements under Medicare and Medicaid. I think that could be a win-win. Unfortunately, there's not the funding for it and there's not the time for it. It would take time and it would take lots of money, because remember, the federal government would have to get involved in owning hospital systems. But it could work. It works in nations like Germany and across other nations like even Taiwan and some others. So that's part one. Part two, and where I'm okay with the public option, is specific to children. And I actually write about this in The Cure. And again, I'm a father. I've got 3 kids. And a kid can't get a job if they need health care, right? They're reliant upon a parent's ability to get a job. I do not think that in the greatest country in the world, we should see a system that profits off of children's health care. I'm sorry, I don't. That's a personal preference. That's arguably the only political statement you'll hopefully hear me say today. I just don't believe that that should happen. And I think that as we start to think about child health care, I should say, it is extremely, extremely expensive. The cost of preemie babies is one of the highest costs in the country, and rightfully so, from a perspective of these are children, we want to make sure they're okay. But sadly, and I'm talking about everybody, but many hospital systems recognize that that is a heartstring that they can certainly pull on to generate extensive amounts of profit. And that's a shame. And so if there was one area where I would say that I would be okay with the government kind of doing a blanket thing, I would say that it would be in child health care. Although I would not do it as a public option, I would do it similar to what we do on Medicare. So understand that Medicare is actually not government. That's government funded private health insurance in reality, right? So there are through the Medicare supplement programs. So it's usually the private pay system. And if we did something like that, For children, I'd be all on board with it. I'm not on board with a public option for children that would be government run, but I would be in charge of it in the other way. There's my political statement. You can agree or disagree with me, and that's okay. But that's my take. Oh, by the way, let me talk about this real quick. I know we're running short on time. The public option, here's its biggest challenge: money. Money. Now, of course, that doesn't seem to concern Washington much these days, but even by ways of which Joe Biden has proposed he would pay for said public option, he's about $850 billion short by many estimations over a decade. That's almost $1 trillion. Now, don't get me wrong. The federal government seems to throw around money like a rock star at a nightclub these days, and they don't care about the federal budget all that much. But that would certainly be a problem. And given the slim margin in the Senate, I do think that that's one area that would be very challenging for the Biden administration to get across the board.
Gotcha. Awesome. Okay, so now let's transition just to takeaways for business owners.
Yep.
What do I need to be thinking about? What do I need to be doing as a business owner, just to either actionable steps I can take leaving this call today, or just things to keep on my mind as this environment and this landscape changes?
Yep. Excellent, excellent, excellent. So 2 things. First is recognize that businesses of healthcare, and I'm talking about large conglomerate hospital systems. I'm not going to name anybody, CHI, but I am going to talk about, did I say that out loud? I was a cough. Don't worry about it. But I am going to talk about the fact that the large business side of healthcare from large conglomerate hospitals, right? Not your regionals or independents, and pharmaceutical industries, PBMs, and health insurance companies. They never let a crisis go to waste, right? If there is a drip, they will stick a bucket there. And what I mean by that is, with any type of confusion, there will be opportunity for margin for these big conglomerates, because again, they're not run by the medical profession anymore. They're run by businessmen and women, and they're very good at business, and their primary objective is shareholder return, not patients. Okay, and they're really good at their jobs. And so expect that as an employer. Remember this, and if you've been on our roundtables, you know this by now, at least, I hope. Your premiums are a derivative of your claims. Shopping insurance doesn't lower your cost, okay? Reducing claims or price of claims reduces your cost. So what we could expect as a result of any confusion or government involvement is that claims likely will go up, which means that you will have to be more engaged. There is a movement of hospital systems across the country deciding to get out of the rat race of what insurance companies are doing and do some things independently and say, we want to go directly to employers and negotiate contracts. They're doing it, whether that's through direct to employer contracts or even doing it through some of the insurance contracts through companies like Aetna. So Aetna has done a very good job nationwide of allowing hospitals to engage in a new way of approaching the market. So other carriers that will remain nameless don't. So that would be one thing, is recognize that there's going to be opportunity. That means prices are going to inflate. So you need to make sure that you're set up appropriately to engage in that. The second piece of that is, if you are bundled with one carrier, you are not doing yourself any favors. If your stop loss carrier, your administrator, and your PBM are all 3 the same company, you're getting it handed to you. That's just a reality, because those companies can cost shift within themselves to make it look like they're giving you a good deal over here because they're making it up on the back end over here. Your best thing to do is make sure that those things are interdependent of one another, that you have a different stop loss carrier, administrator, and PBM, that those 3 are not linked in any way, shape, or form. That is your best opportunity to make sure that there's some level of checks and balances and engagement. The other piece of this is, if you are not reviewing data on a regular basis, you're doing yourself a massive disservice. And when I say reviewing data, I'm not just reviewing backwards data. I'm talking about forwards data too. So as part, and we've talked about this in other conversations, as part of the Affordable Care Act, the United States transitioned to ICD-10 coding. I told you I was a geek. And that means that we can now forecast out expenditures. Big data is a thing. Data mining is a thing. We can take big data and understand that if you have a 35-year-old in Lincoln, Nebraska on Lipitor that makes $55,000 a year, exactly what that person is probably going to cost you over the next 12 months. Insurance companies are doing that. You should be doing that too. It's your money at the end of the day. And so these are the primary things that I would focus on, and always make sure you've got somebody advising you on the latest of what's going on from a compliance perspective. This is certainly not something you want to make sure you want to be behind the times in. There is no ignorance protection in the law. And then the other thing I would say is recognize that and a lot of things I've talked about are not available, sadly, for employers under 25 employees. Okay, that's just the sad reality of it. So everything that I just mentioned can be done if you have more than 25 employees. Okay, that's the truth. If you're below 25 employees, it's not that it can't be done, it's just much more difficult. So you just want to make sure that you're staying on top of what's going on. Recognize that in reality, if you're less than 50 employees, I would argue that you may have the multitude of options, because you can, if it makes sense, move into a platform that's going to give you data transparency, the ability to unbundle everything that's going on if it makes sense. But you also have the safety net of community rated, fully insured plans that if this goes bad, you can go back. And so there's a pro and a con. The reality is, and this is the saddest part of this entire story, anytime the government gets involved in anything, the people that get squeezed the most are the smallest of employers. That's just truth. So employers under 25 employees, buckle up. I wish I could tell you something different, but it's going to be an interesting ride for you. And unlike the Trump administration, who really wanted to put control back into employers and consumers' hands, the Biden administration, by all indications, is going to say, we're the government, we know what's best for you. I love the line from Ronald Reagan, which was the most scary words that you can ever hear, is I'm from the government and I'm here to help. And I think that that's certainly the case when it comes to healthcare. So we all just need to keep a watchful eye and make sure that we're staying well informed. You're doing a good step by being part of this here. If you have specific questions, I would tell you reach out to us, or reach out to somebody that's a trusted advisor, not just somebody that shops insurance.
Absolutely. And, I think it is fair. It's good that, Seth can give us the unbiased and not watered down opinion, because it is frankly it's a tough environment in a small business right now. Back to Michael's question, I don't think we quite know how it will impact small employers quite yet, but it certainly will. The couple things that we do talk a lot about is the strategies still apply, that we can, a lot of times in a larger organization, that we can see the direct impact on. We just may not be able to see the direct impact in a small employer, but all of those things do apply and do have an impact over the long term. It is very much open season in the future here on what's going to happen. So we will be proactive, I think, is the biggest thing. We're going to be doing more of these education events to try to keep everybody up to speed on what's changing.
Let me say something to that, Elliot, real quick, because I think you just made a fantastic point, and it was something I was going to say. Don't be reactive. Don't do what sadly many employers did after the Affordable Care Act passed and put your head in the sand and say, I will wait to see how it's going to impact me. It's too late. It's too late once that happens. You need to set yourself up for success, stay engaged, stay informed. If you are making your decisions on your employee benefit plan once a year, and that's the only amount of time you're engaging in this, you are doing it all wrong. And for my friends that are in the HR world that may be on the call, I apologize. I apologize from an executive level that oftentimes you're left to try to make executive level decisions because of a lack of an engaged executive team. This is certainly one of those things, and I'm not trying to call anybody out, although if that's you, I'm calling you out in the nicest way I possibly can. Elliot said I don't water things down. This is an executive level engagement. If unless you're one of those rare employers that healthcare has not become one of the top 5 expenditures on your P&L, if you're one of those people, keep doing whatever you're doing because you're doing it right. But if that is you, this needs to be an executive level conversation that you're engaged in. If nothing else, checking in at least once a quarter to understand what's going on, to get an update on what's going on in the market, in the political sphere, what's coming down the pike. Most of you run your businesses very effectively. You understand supply chain. If you've been on our calls before, you understand that healthcare is a series of supply chains. What's your healthcare supply chain? As an executive team, you need to be informed of that. And if you're not doing your best to make sure that you're controlling costs and maximizing EBITDA.
Absolutely. And Michael, let me know if there's any more clarity we can provide around that question, just making sure that we got it answered for you. Amy, I agree. You can't spell hero without HR. So
boom.
I think that's
most undervalued position in the business, I would say.
We did have one more kind of question come in, Seth here. Questions from Kenzie. If our PBM, stop loss carrier, and insurance carrier are all connected, as you've mentioned, how do you recommend we proceed in lowering costs?
Mm-hmm. It's a great question. First of all, it's get the data. Have an independent review done of that. So the easiest place to do that is the pharmacy side. It's your data, right? So the pharmacy is assuming you're self-funded. If you're fully insured, you have forfeited your right to data, sadly. And by the way, maybe go back and listen to some of our other roundtables where we talk about self-funded is a scary term, and I wish it wasn't called that because, by the way, nobody's self-funded. Nobody is completely. You all have limits to your risk. But nonetheless, if assuming that you're in a self-funded ERISA-based platform, and those three are the same, the easiest place to look is at the pharmacy. So you have an independent PBM review done. If you don't know where to go get that done, reach out to us at Ellerbrock-Norris. We can certainly do that. I would encourage you, whoever is going to do that for you, and I guess if we represent you, do this too. Don't have your current broker do it. Just because there may already be a conflict of interest. I'm not calling out any brokers that may, you may have a relationship with. It's important that if those two are linked, then you need to have an independent study done, because rarely do people want to admit when they've made a mistake. And if I'm advising you and I've linked to those two, I may have made a mistake. And certainly you would be less likely to get an honest opinion there.
Yeah. Yeah, Kenzie, sounds like that answered the question. If it did not, let us know. But, we had another interesting one come in, Seth, which I haven't seen anything in Biden's campaign promises to address this, but I think it's really important we talk about the hospital's compensation, we talk about the insurance company compensation. We haven't really discussed broker compensation in this whole piece, which I think is a very important piece because a lot of what that compensation includes is hidden from the employer as well. So maybe address your thoughts on that, or if we might see anything I'll just leave it at that. If there is anything that you've seen that might address that.
Yes, and it's an excellent point. So as a matter of fact, the last round of government assistance for COVID, the last COVID relief program, I'm usually a huge fan of no earmarks. I was a big fan of this one because what this earmark said was that it addressed broker compensation in the health insurance market. And it said that brokers are now required to be completely transparent on their compensation. Now, the reason I'm okay with that is because we've done that for years at Ellerbrock-Norris. So we're always transparent about our compensation. And most people don't understand broker compensation. Now, here's where I'm worried that that's going to get lost. First of all, if you didn't know that was something, it's not likely your broker is going to announce it to you. And then secondarily, there was not a lot of clarity as to how that had to be disclosed. Now, if you're over 100 employees, there's already 5,500s that have to be done, and you can certainly see broker compensation there. That's 5,500 means that the compensation is built into the plan. It has to be disclosed. If it's built outside the plan, then it's already disclosed because obviously you're writing the check. But if it's built in the plan, it has to be done through 5,500. But there's still ways that they can hide compensation. The easiest place for brokers to hide compensation is in the PBM. So earlier, I think Kenzie asked the question about, do we do an independent analysis? That's where, yeah, you want an independent one, because brokers all the time, and I will tell you, we get approached at Ellerbrock all the time by PBMs offering us extensive amounts of monies and bonuses if we will link the carrier and the PBM together. Stupid amounts of money. One employer recently, they may be on the call, I'm not going to mention by name, specifically their carrier reached out to us and said that they would offer us $30,000 cash day one if we would link the PBM. And this is a 50 life employer. That tells you how much money is in that. Obviously, we declined their offer. But that's the thing. If we would have accepted that offer, the employer would have never known, because there's no requirement of disclosure. So I'm anxious to see how this most recent thing plays out, because it says that they have to disclose things like that. How that's going to happen, I don't know. Interestingly enough, when the Affordable Care Act passed, a lot of insurance companies started calling commissions fees to get around the 85% MLR, and they buried in the back of a master application that likely very few employers read the fee page. And so as part of your signing 20 pages, you got to that 20th page, or usually the 19th, because they don't have to be the last page, because people actually look at the last page. It's got to be hidden somewhere in there. And then they would sign it, not realizing they just signed over their broker compensation. If your broker is compensated through the carrier, it's likely that any increases you get is also being viewed as an increase to the broker, because that is, they go in line with one another. So that is a part of the law. We'll wait to see how it gets rolled out. Like most things in government, it's probably not going to happen quick. And like most things in the health insurance system, there'll be somebody that figures out a way to hide it. But now you know it's there, so now you can ask your broker for
it. Absolutely. So I think we've answered all the questions that we have so far. We will certainly, we're at time here, 10:30. We will certainly remain on for a few minutes in case we do get a couple other questions or whatnot. But thank you, everybody, for being a part of the call today. I hope it was very informative. If you have additional questions that you didn't want to send to the group or have us address as a group, please reach out to one of our advisors. Many of our team is on the call today, and we will get those answers for you and make sure that we are being proactive in a lot of this stuff as much as possible. Stay in tune for a couple things: the survey that'll go out after the call, as well as future educational series and events. And if you have ideas for things you'd like to see us do more of these types of calls on, let us know. We're always looking to bring valuable and topical content to all of you as clients and relationships of Ellerbrock-Norris. So we'll stick around for a bit, but thank you, Seth, and thank you for everybody that was on the call.
Thank you. And by the way, the book that we're offering up to everybody, I will say this: the book was written as a blueprint for solving America's healthcare crisis, and it was written in a way that it was really meant for Congress to say, hey, if you really want to solve this thing, here's some basic steps to do it. I personally believe that America is a really big business as far as the way that the government is and operates things. They don't run a very efficient business, but they run a business anyway. Where I'm going with that is everything that we talk about in the book, many things you can do. So if you're an employer and you want a blueprint that kind of gives you some ideas, some things that you could be doing, you'll find it in the book.